Ladies and gentlemen, thank you for joining our scientific webinar powered by Omnia Health and sponsored by Beckman Coulter Diagnostics, Middle East and Africa. My name is Grace Estefan, and I'm the Marketing Communication Manager for Middle East and Africa region. Our webinar will focus on the importance of running the right and precise diagnostic parameters to detect the deadly sepsis disease in an emergency environment and in all environments. Our speaker, Dr. Matilda Merve, is a medical doctor who graduated from Gazi University in Turkey. She has worked as a physician in the primary healthcare and the emergency care for more than 10 years, then decided to pursue her education and did a PhD from Ankara University in Turkey in pharmacology. She then moved into the industry with the role of medical manager and joined us recently as a scientific manager for Beckman Coulter Middle East and Africa region. We are very happy to have Dr. Matilda join us, and we will start with the presentation and the question and answers. Please, you can put them in the box where you have question and answers, and at the end of the session, you will be asked to run a very short survey of a couple of questions in order to understand whether the message we portrayed was interesting to you and whether really you see any value in our presentation. Thank you again, and the floor is to Dr. Matilda.
Thank you very much, Grace. Ladies and gentlemen, good afternoon. It is my honor today to be here and to give you a presentation on procalcitonin as a sepsis biomarker. During this presentation, I will try to cover topics about sepsis definition and pathophysiology, what are the biomarkers of sepsis, procalcitonin as a biomarker and its clinical use, and last but not at least, I will talk about the Beckman Coulter's access procalcitonin assay. Firstly, if we have a look at the sepsis definition, we may say that it's the life-threatening organ dysfunction due to a dysregulated host response to infection. It is a burdensome condition worldwide in terms of morbidity, mortality, and financial cost to health systems, of course. But still, data for the global burden of sepsis are limited. A recently published analysis of global burden of disease, injuries, and risk factors has revealed that 49 million cases of sepsis and 11 million sepsis-related deaths were recorded worldwide in 2017. And this represents approximately 20% of all global deaths. In the United States of America, about 1.7 million sepsis are reported each year. The World Health Assembly recognizes sepsis as a significant threat to patient safety and global health and has intensified its approach to the prevention, diagnosis, and treatment of sepsis in order to improve patient outcomes and reduce mortality. Many patients with sepsis present to the emergency department. International clinical practice guidelines recommend promptly identifying sepsis and start appropriate treatments such as with broad-spectrum antibiotics, agents, and intravenous fluids. These recommendations are supported by many studies suggesting that early treatment with antibiotics and intravenous fluids could reduce the number of deaths. But there is also controversy about how rapidly sepsis must be treated. Some clinicians question the potential benefit of rapid treatment, the potential for adverse effects, and the challenging implementation of these efforts in environments where staff are often overworked. The results of this study of Dr. Kammer and his colleagues were robust, and showed that for each hour of delay in antimicrobial administration after the onset of the septic shock, in-hospital mortality increased by an average of 7.6%. Not surprisingly, prompt antibiotic administration in patients with septic shock is paramount. Healthcare providers are the critical link to preventing, recognizing, and treating sepsis. Therefore, the earlier sepsis is recognized and the earlier the treatment starts, the better the outcome for the patient and the lower the cost that can be expected by the healthcare system. It is difficult to diagnose sepsis. First of all, defining sepsis is a challenging task as it is not a definitive disease. It is a heterogeneous condition of different etiologies and severity, may manifest in different ways. It progresses quickly and can be confused with other conditions. Also, sepsis signs and symptoms can be challenging to identify because the highest incidence of sepsis occurs in individuals that are either elderly or who already have a chronic disease. Early recognition and timely management are essential to help reduce sepsis-associated morbidity and mortality. In contrast to other specialties where diagnostic laboratory and radiological tests with high sensitivity and specificity exist, the diagnosis of sepsis is more complicated. There are two main elements to this problem. On one hand, organ dysfunction has to be recognized early, and resuscitation measures must be started without delay. On the other hand, the nature of the underlying infection has to be clarified. Unfortunately, conventional indicators of infection such as fever, leukocytosis, etc., have poor performance in the critically ill patients. Doctors try to utilize both clinical findings and laboratory tests to help with the diagnosis. In 1991, Consensus Conference developed initial definitions that focused on the view that sepsis resulted from a host systemic inflammatory response syndrome to infection. Sepsis, complicated by organ dysfunction, was termed severe sepsis and could progress to septic shock. In 2001, a task force recognized the limitations with these definitions and expanded the list of diagnostic criteria, but it did not offer alternatives because of the lack of supporting evidence. And lately, in 2016, there was a new definition of sepsis called Sepsis 3, and according to this definition, sepsis is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. The sepsis-related infection and organ dysfunction is assessed by the sequential organ failure assessment score, and the previous expression that was severe sepsis is no longer used. This new definition emphasizes the primacy of the non-homeostatic host response to infection, the potential lethality, and the need for urgent recognition. With this slide, I would like to focus more on the new sepsis criteria. As I mentioned previously, sepsis definition includes infection and organ dysfunction, and septic shock is a subset of sepsis in which underlying circulatory and metabolic abnormalities are profound enough to increase mortality. Patients with septic shock can be identified with the clinical construct of sepsis plus persisting hypotension requiring vasopressors. There are various scoring systems to assess the organ dysfunction severity. Those systems can quantify abnormalities according to clinical findings, laboratory data, or therapeutic interventions, but the predominant assessment score in current use is the sequential organ failure assessment, which is called SOFA. It is possible to identify organ dysfunction as an acute change in total SOFA score equal to or more than 2 points. The baseline SOFA score can be assumed to be 0 in patients not known to have pre-existing organ dysfunction. A SOFA score of 2 reflects an overall mortality of approximately 10% in a hospital population with a suspected infection. Sometimes it's not easy to apply SOFA score outside the intense care unit, so the quick SOFA or Q SOFA was introduced for a rapid bedside assessment. The criteria used in the Q SOFA were an altered mental status, systolic blood pressure equal or less than 100 millimeter of mercury, or a respiratory rate equal to or greater than 22 per minute. However, just to be aware that the Q SOFA is not as suitable as a screening tool as it lacks sensitivity. Guidelines recommend urgent administration of antimicrobials when sepsis is suspected. As you see, NICE guideline and Surviving Sepsis Campaign guideline, which is new published this month, both these guidelines recommend administration of antimicrobials as soon as possible in patients with sepsis. As early recognition of sepsis is important, is it possible to have biomarkers that will help about it? Sepsis is fundamentally an inflammatory disease mediated by the activation of the innate immune system. It is characterized by an increasing production of inflammatory cytokines, such as tumor necrosis factor, interleukins. The kinetics of expression of the various biomarkers that are produced following the onset of infection is essential to understand their clinical relevance. The cytokines are expressed relatively quickly following the infection and then followed by procalcitonin and then by the C-reactive protein. If the blood is taken 2 hours after the infection, then procalcitonin and the C-reactive protein will not be beneficial to detect the infection compared to the cytokines. And it is the opposite if the blood is taken later at 12 or 24 hours. From the kinetic studies, we can also notice that procalcitonin has rapid clearance following the resolution of infection. Only a few biomarkers reflect the early events related to the infection that is triggering the sepsis cascade. Several biomarkers, such as liver enzymes or lactate, reflect the physiological consequences of the dysregulated inflammation leading to organ failure. During a normal inflammatory response, the production of these cytokines is beneficial. It's required to repair tissue damage. However, an excessive inflammatory response can cause lethal multiple organ failure and become more dangerous than the initial insult itself. At least 178 different sepsis biomarkers have been described in the published medical literature. All these biomarkers reflect the complex pathophysiology of sepsis, such as coagulation, complement system, contact system activation, inflammation, and apoptosis. There is also biomarkers of complications, for example, troponin for myocardial dysfunction. Sepsis biomarkers may provide information beyond what is available using other metrics and could help clinicians to improve patient management. For example, more timely and appropriate antibiotic therapy could be administered and unnecessary antibiotics use may be avoided if biomarkers were available that could accurately diagnose sepsis early. Similarly, biomarkers could help physicians monitor the effectiveness of therapeutic decisions and adjust treatment if necessary. Amongst the many biomarkers used in sepsis, procalcitonin, C-reactive protein, and interleukin-6 are the ones that have been the most studied. As shown in this meta-analysis, many studies have demonstrated the performance of the procalcitonin for the early detection of sepsis, and according to this study, procalcitonin is showing a large area under curve with relatively good clinical sensitivity and specificity for the detection of sepsis. Then let's have a look on procalcitonin as a biomarker for sepsis. Procalcitonin is a prohormone of calcitonin, the latter being involved with calcium homeostasis. In physiological conditions, calcitonin is secreted by parafollicular cells of the thyroid, and in sepsis, the main producers of procalcitonin are macrophages and monocytic cells of different organs, especially liver. Normal values of procalcitonin are lower than 0.1 nanogram per milliliter. In healthy individuals without an inflammatory situation, procalcitonin is produced and converted to calcitonin, as I said, within the C cells of the thyroid glands, and it presents very low serum levels. When an infection occurs in the individuals, procalcitonin production process is alternatively and independently triggered by bacterial endotoxin and inflammatory cytokines, and it starts to take place in many extrathyroid organs, including liver, lung, kidney, pancreas, brain, heart, and small intestine. The first study to investigate the usefulness of procalcitonin in patients with infection was published in 1993. In this study, it was mentioned that a substance immunologically identical to procalcitonin is increased at the onset of infections, and serum concentrations of this substance seem to be correlated with the severity of the infection. Another study explored the kinetics of procalcitonin and found that after infection, procalcitonin increases within 2 to 6 hours. It has a peak between 6 to 12 hours and then follows a decrease after 24 hours and normalization within 5 days. The half-life of procalcitonin is about 25 to 30 hours. This study of Dr. Müller included 925 patients with community-acquired pneumonia. We know from the guidelines that in hospitalized patients with suspected community-acquired pneumonia, blood culture sampling is recommended. This study investigated the benefit of procalcitonin on hospital admission to predict blood culture positivity. Overall, procalcitonin was a significantly better predictor for blood culture positivity than white blood cell counts, C-reactive protein, and other clinical parameters. The cutoff of procalcitonin was 0.1 nanogram per milliliter and would identify 99% of the positive blood cultures. It is mentioned in the study that procalcitonin measurement can reduce the number of drawn blood cultures in the emergency department and implement a more targeted allocation of limited healthcare resources. After all, some questions were raised. Can procalcitonin measurement help differentiate between bacterial infection and other kinds of inflammatory processes? This is the study that investigators evaluated the accuracy of procalcitonin to discriminate between viral and bacterial pneumonia. They found higher levels of serum procalcitonin at hospital admission to be strongly associated with increased probability of bacterial pathogen detection, and nevertheless, no procalcitonin threshold allowed for perfect discrimination between viral and bacterial detection. So clinicians cannot rely on procalcitonin alone to guide antibiotic treatment decisions. there is an unmet need for clinical or laboratory tools to distinguish between systemic inflammatory response syndrome and the various forms of sepsis. Unfortunately, no single clinical or biological indicator of sepsis has gained acceptance. Among the potentially useful sepsis biomarkers, interleukin-6, interleukin-8, and procalcitonin have been proposed to be the most promising candidates. The aim of this study was to assess the diagnostic value of procalcitonin, interleukin-6, and interleukin-8, and standard measurements in identifying critically ill patients with sepsis. As a result, baseline plasma levels of the inflammation markers, interleukin-6, interleukin-8, and procalcitonin, were higher among case subjects with severe sepsis or septic shock than among the control subjects with systemic inflammatory response syndrome only. Procalcitonin yielded the highest discriminative value with an area under curve of 0.92, followed by interleukin-6 and interleukin-8. The relation of procalcitonin plasma concentrations compared with the C-reactive protein was also analyzed in patients with different severity of multiple organ dysfunction syndrome and systemic inflammation. Higher SOFA score levels were associated with significantly higher procalcitonin plasma concentrations, whereas C-reactive protein was elevated irrespective of the scores observed. Moreover, results indicate that procalcitonin concentrations are associated with the severity of multiple organ dysfunction syndrome as assessed by the SOFA score. Early diagnosis and initiation of resuscitation measures, antibiotic treatment, and source control remain the cornerstone of sepsis care. Once treatment is initiated, close monitoring of sepsis patients is of utmost importance to identify patients with adverse disease courses who may require an alternative therapeutic approach. In addition to clinical signs and symptoms, blood markers may assist in patient monitoring. Procalcitonin is a host response biomarker that is upregulated by microbial toxins and certain pro-inflammatory mediators and is downregulated during recovery. In addition to its diagnostic value, the kinetics of procalcitonin has also been shown to predict mortality and treatment failure in sepsis. This is the study that aimed to validate the prognostic accuracy of an inability to decrease procalcitonin by more than 80% from baseline to day 4, so to predict 28-day mortality in patients with severe sepsis or septic shock. Monitoring procalcitonin in this patient population was demonstrated to aid in risk assessment, translating into better informed clinical decisions regarding the intensification of care or intense care unit discharge. In conclusion, the inability to decrease procalcitonin by at least 80% is a significant independent predictor of mortality and may aid in sepsis care. Judicious use of antibiotics is of vital importance in clinical therapy. Inappropriate use of medicines may lead to the development of antibiotic resistance in patients. Clinicians need tools to control unnecessary antibiotic prescribing as well as ensure the efficiency of treatment. So it is possible to have therapeutic decision in patients according to the level of procalcitonin. After the FDA approved the blood infection marker procalcitonin for guiding antibiotic therapy in patients with acute respiratory infections, Dr. Schutz and his colleagues published this meta-analysis of patient data from 26 randomized control trials. They tried to assess the procalcitonin-guided treatment in patients with acute respiratory infections from different clinical settings. As a result, they found procalcitonin guidance associated with a 2.4-day reduction in antibiotic exposure. Also, mortality rate at 30 days and antibiotic-related side effects were significantly lower in procalcitonin-guided patients than in control patients. Studies dedicated to clinical decision levels of procalcitonin showed that in non-septic conditions, plasma procalcitonin concentrations are found to be below 0.5 nanogram per milliliter. Concentrations exceeding 0.5 nanogram per milliliter but less than 2 nanogram per milliliter should be interpreted in the context of the specific clinical background and conditions of the individual patient. It usually rules out bacterial sepsis infection, but localized infections are still possible. In these cases, it is recommended to repeat the measurement after 6 to 24 hours until a specific diagnosis is identified. Procalcitonin levels above 2 nanogram per milliliter, but less than 10, are highly suggestive of an infection process with systemic consequences. Still, procalcitonin results should be used in conjunction with all laboratory findings and full clinical picture of the patient. Concentrations above 10 nanogram per milliliter are almost exclusively found in patients with severe sepsis or septic shock. It's an indication that the sepsis treatment is not under control and associated with poor prognosis. This month, November 2021, Critical Care and Medicine published the guideline for sepsis and septic shock. There were 2 recommendations dedicated to procalcitonin. We suggest using procalcitonin and clinical evaluation to decide when to discontinue antimicrobials over clinical evaluation alone. And another recommendation was about using procalcitonin plus clinical evaluation to decide when to start antimicrobials as compared to clinical evaluation alone. In the guideline, it is emphasized that procalcitonin should not be used alone. Clinical evaluation should always be taken into consideration before the clinical decision. Access procalcitonin assay is part of Beckman-Coulter's comprehensive assay menu, hence the intended use to aid in the risk assessment of critically ill patients for progression to severe sepsis and septic shock. How to interpret procalcitonin results of this assay? Procalcitonin concentrations that are less than 0.5 nanogram per milliliter may predict low risk of severe sepsis or septic shock, and procalcitonin levels between 0.5 and less than 2 nanogram per milliliter may predict about moderate risk of progression to severe sepsis or septic shock, and levels that are equal to or higher than 2 nanogram per milliliter predict for high risk of severe sepsis and or septic shock. Beckman-Coulter offers a broad range of tests for different clinical utilities that can help the physicians assess and manage sepsis. Routine tests are ordered when symptoms are unclear and applied broadly as patients present to the healthcare system. When there is a suspicion of infection or sepsis, early sepsis indicators such as MDW or monocyte distribution wides, tests such as lactate, procalcitonin, C-reactive protein, and interleukin-6 can aid in patient assessment. Before closing my presentation, I would like to summarize that sepsis is a frequent, severe, and high healthcare burden disease. Early diagnosis and treatment intervention reduces sepsis specific mortality, and procalcitonin is an important biomarker that can aid for the risk assessment of critically ill patients for progression to severe sepsis and septic shock. It is important to note that procalcitonin results can become elevated by causes other than systemic bacterial infections, including burns or trauma, etc. Therefore, procalcitonin should not be used alone, but always in conjunction with patient history and other clinical presentations. Thank you very much for your attention.
Thank you all for attending, and thank you, Dr. Matilda, for this informative session. Now we open the floor to questions, and hopefully we'll have all the answers that you have raised, to the questions that you have raised. The first question that I received is, what are the main characteristics of Access PCT assay?
Yes, sure. Access procalcitonin assay is a two-step sandwich assay format. It can be used you can use serum or plasma lithium heparin sample types. Time to the first result is about 20 minutes, and the open reagent pack stability is 42 days. Open calibrator vial stability is about 90 days. And this test has high sensitivity with limit of quantitation 0.02 nanogram per milliliter, and has a low end precision such as coefficient of variation is less than 8%. 8%, yes.
Thank you for answering the first question, and I encourage all attendees to write their question in the box on the right labeled Q&A. So the second question, Dr. Matilda, is there any data to support the accuracy of the Access PCT assay?
The Access procalcitonin assay was designed to align with Braham's methods and use the bioMérieux Vidas procalcitonin method as its predicate. Method comparison and concordance studies have been performed and have demonstrated strong correlation and concordance. There are also some detailed data about this in the instructions for use of Access procalcitonin assay.
We have a question as well asking about false positives in PCT assays results.
False positive procalcitonin, actually I don't have data about that, but I need to check it because I didn't see any data about false positivity for procalcitonin assays. But as I mentioned, procalcitonin, it may increase concentrations not only on bacterial infections. There are also some other diseases that procalcitonin may increase. So if you mention false positive about this, yes, it is possible that you can have positive procalcitonin concentrations tests in patients that are not in sepsis, but other diseases, possible.
A new question. So what is the difference between Access PCT and PCT BR HAMS? Is there any comparative studies comparing both parameters?
Yes, there are comparative studies, and these studies showed strong correlations and concordance with each other. Yes.
Can we consider the PCT assay as a gold standard for sepsis diagnosis, or do we have other options?
As I mentioned, sepsis is a really difficult disease to be defined because of pathophysiology. Procalcitonin is one of the biomarkers that can help for defining this disease. But also there are also biomarkers, and as I mentioned, maybe other parameters such as MDW, but it is not, we may not say that it is the gold standard, because when considering procalcitonin concentration levels, clinicians should always take into consideration the clinical nature of their patients. So laboratory and clinical characteristics should be considered together.
Thank you for all the French-speaking attendees. So it's good that I understand French and I can translate the question. The new question says, what are the levels of PCT for all patients in the intensive care units under reanimation?
Procalcitonin levels in normal individuals are expected to be lower than 0.1 nanogram per milliliter, but if depends on the, of course, on the disease and severity of the disease. And as I mentioned before, there were some levels how to interpret procalcitonin results. That was if the procalcitonin concentration was 0.5 nanogram per milliliter, less than 0.5 nanogram per milliliter, then it can be predict low risk of severe sepsis. And this concentration, if it is between 0.5 and less than 2 nanogram per milliliter, then should predict a moderate risk of progression to severe sepsis or septic shock. And if procalcitonin concentrations are higher, equal to or higher than 2 nanogram per milliliter, then there is a high risk of severe sepsis or septic shock. This is how we can interpret procalcitonin concentrations.
We were asked to repeat the answer referring to whether PCT is the gold standard test to detect sepsis, because there was a system glitch.
Okay, of course, sure. As I mentioned, there are the sepsis by itself is a difficult disease to get defined. And there are a lot of biomarkers used in the laboratories that are used to help to define sepsis. Procalcitonin is one of these biomarkers. Also, for early sepsis indication, there are parameters such as monocyte distribution whites, for example, that can be used for early sepsis indication. What I should say is that all guidelines recommend to use procalcitonin levels not alone, but always with clinical consideration. So clinicians should be careful to, while they interpret procalcitonin levels, that they should take into consideration the patient's clinical characteristics.
A new question for the diagnosis of sepsis. Should we use only the SOFA score or the procalcitonin levels? Which one should we use, and whether we need to use both as well?
Well, regarding to the guidelines, SOFA score is used to assess the organ dysfunction during the sepsis, but to define sepsis itself, I mean, the clinicians' clinical practice is that they use the SOFA score and also other biomarkers and also procalcitonin and also the clinical condition of the patients. It is not that every parameter should be used one by itself. There is a complexity of these parameters, I mean. They need to be considered all together.
Dr. Matilda, what is the cutoff for PCT results in critical patients?
Well, I think there are a lot of questions about how to interpret procalcitonin results, so I'm still going to repeat how to interpret. These are the results of access procalcitonin assay. Please take it into consideration. If procalcitonin concentrations are less than 0.5 nanogram per milliliter, then you can interpret as a low risk for severe sepsis and septic shock. If these concentrations are between 0.5 nanogram per milliliter but less than 2 nanogram per milliliter, then there is a moderate risk of progression to severe sepsis or septic shock. And if the procalcitonin results, I mean access procalcitonin assay results, is higher than or equal to 2 nanogram per milliliter, then the high risk of severe sepsis and septic shock is indicated in this situation.
A new question: can sepsis be a result of other infections, including viral infections such as COVID-19 and influenza?
Sorry, Grace, can you repeat it again?
Whether the sepsis may happen as a result of other infections, especially COVID-19 or influenza.
Actually, this is a topic of discussion about COVID-19 and other viral infections. During my presentation, I mentioned that there are some studies that try to discriminate between viral infections and bacterial infections. But what can we say about procalcitonin is that there is not a definitive threshold that can discriminate between viral and bacterial. What I mean viral includes all viral infections such as COVID and influenza. But there are a few studies, as far as I know, that are undergoing right now in patients with COVID-19.
We still have two questions. So how do we have to monitor PCT, or what are the results that we need to look at if the patient is like having an antibiotic therapy?
Procalcitonin levels, in some studies, it's mentioned that procalcitonin levels may be used to guide the antibiotic therapy. That's right, but for procalcitonin access procalcitonin test, there is not such an indication. So this is a little bit off-label, I mean.
Is there a difference between presepsin and procalcitonin?
To be honest, I don't know. I need to check it out.
And the last question, is there any cross-reactivity between access PCT and biotin?
Well, I can answer that definitely not, because the access procalcitonin assay is not susceptible to biotin interference as assay, and it does not use streptavidin biotin particle chemistry. So my answer is no, definitely not, no interaction.
No further question. We really like, as Beckman Coulter, to thank you all for attending our session. Hope really that we enjoyed and you enjoyed it, and hope that we added value as well to what you know about PCT assays and all our available assays. Please, there's a new question. I don't know if we can run it through. Is the PCT related to heart disease also?
Heart disease? Procalcitonin
yes.
to heart disease? Well, I should definitely mention the intended use for the access procalcitonin that it aids in the risk assessment of critically ill patients for progression to severe sepsis and septic shock. So I'm afraid not.
Okay. So we thank you all. Hope you enjoyed the session, and please leave your feedback in the survey box. And we hope to see you again, like attending our future webinars. Thanks a lot. Thank you, Dr. Matilda, and thanks Informa for like all their arrangements and logistical help. All the best, and see you next month.
Thank you. Bye-bye.
Bye.